which is common electrolyte disturbances or common electrolyte imbalance in the children. Now let's talk about some basic things first before we move on to the abnormality. What is the composition of major cation and anion in the plasma and in the intracellular compartment? Now just pay attention on your screen. In the plasma, the dominant or most important cation is the sodium. Cation means positively charged ion, anion means negatively charged ion. Okay, so very clear. So the dominant cation or positively charged ion is a sodium in the extracellular fluid. Plasma is the example of extracellular fluid. Whereas, okay, so look at the concentration of potassium in the extracellular compartment, just 4. This is milliequivalent per liter. This is very, very important for you to remember. Whereas regarding the anion, chloride is the dominant one in the extracellular fluid, and the second on the list is bicarbonate. Both are anion. In the intracellular compartment, the dominant cation is potassium now, exactly opposite than extracellular. Potassium, okay, is the dominant one, and after that it's sodium. Regarding the anion, the phosphate and the protein, they are predominant in the intracellular compartment. Now it has got many clinical implications. So let me describe you few of them. In case of severe cell damage or severe cell death, like a crushing type of injury after a big motor vehicle accident, a lot of potassium will be released from the cells because potassium is present inside the cell, and that potassium will be high in the blood, and we call that hyperkalemia. At the same time, phosphate is also released. See, this phosphate is also present in an excessive amount inside the cell. This phosphate can lead to hyperphosphatemia, and that hyperphosphatemia can lead to hypocalcemia later on. The phosphate and calcium has the inverse relation. Whenever phosphate is increased, calcium will be decreased because they combine together, okay, and then calcium, the free calcium will be utilized. So these are some of the very, very important points. Let's move further. Let's focus on sodium first, and after I have finished sodium discussion, then I'll move on to potassium and then finally calcium. Now regarding the sodium metabolism, this is the dominant cation in extracellular fluid, and this is the principal determinant of extracellular osmolality. There's no doubt about it. Glucose and sodium are the two important substances which determine the extracellular osmolality. Around less than 3% of the sodium is only present intracellularly. Most of that is extracellular. More than 40% is present in the bone, and remainder in interstitial and intravascular space. Now, what is interstitial space? What do you mean by that? Yes? Interstitial. Interstitial.
The space between the two cells.
Space between the two cells. Very good. Very easy meaning, okay? Space between the two cells, or space between the cells is called interstitial space. So this is outside the cell. And if there is excessive fluid collection in the interstitial space, we call this edema. And intravascular space is inside the blood vessel. So our blood, plasma, serum, everything is considered extracellular fluid. So naturally, sodium is much more commonly found in that space than potassium. Now, regarding the intake and excretion of sodium, it depends on the type of diet what we are consuming. If you are eating a very salty type of diet, then we are taking more amount of sodium. In case of children, the breast milk contains around 7 milliequivalent per liter of sodium, whereas formula contains almost double than that. See there, it's a range, okay? It depends on different type of formula. So the range is 7 to 13. If it contains 12 to 13, it is almost double than the breast milk. Now, what is the danger if we give formula? If somebody doesn't know how to prepare formula feeding for the baby now, what is the danger? Yes, quick answer here. What's the danger?
Hyperkalemia.
Hypernatremia, sir.
Hypernatremia.
Hypernatremia. Very good. Hypernatremia. Very easy answer, okay? Because we are talking about sodium. If the excessive sodium is given to the baby may have hypernatremia. And this is the common type of formula. It has 20 calorie per ounce. Now, ounce means it is 30 ml. This is the standard type of measurement, okay? 1 ounce is 30 ml. So in 30 ml preparation, there is 20 calorie of energy. Sodium is absorbed throughout the GI tract with limited regulation. So it is very easy to treat dehydration with oral rehydration solution because it is easily absorbed throughout the GI tract. You already know they have mixed glucose in ORS along with the sodium. Now, what is the function of that glucose? Now, see here, the glucose enhances the sodium absorption. Glucose will easily diffuse into the intracellular compartment, or it will go into the blood from the intestine first, and from the blood it will go into the intracellular space. That's a different thing. But okay, please mute yourself. Okay, so what I'm explaining here, the presence of glucose enhances the sodium absorption. More amount of sodium will be following the glucose. That's why we mix glucose and sodium together in case of ORS. And this is the recommended daily requirement of sodium. It is 2 to 3 milliequivalent per kg per day. And let me remind you one thing, if the person is taking balanced diet, they don't need to worry about the sodium requirement, okay? That will be fulfilled. Regarding the excretion of sodium, it occurs in stool and sweat, but kidney is the principal site of sodium balance and excretion in our body. So it is handled by kidney. If we have increased amount of sodium in the blood, probably kidney will excrete more of that. If we are taking less amount of sodium in our diet, kidney will reabsorb more sodium and try to balance that as well. Okay, so this is the balance done by kidney. Urinary output ranges from 1 milliequivalent per day in case of low salt diet to 400 milliequivalent per day or even more when sodium intake is high. So that's what I told you just now. Our kidneys can balance the amount of sodium in the blood. Now you may ask a question, if kidney can do that, then why is the problem of hypernatremia or hyponatremia, isn't it? The question must come in your mind. And the answer is, these are the physiological things, and every type of physiology has got certain limit. If we continue to push the physiology up to a certain limit, it will give away. Then after that, the pathological condition will arise. With this background information of sodium metabolism, let's enter into the topic of hypernatremia. Now, definition of hypernatremia is sodium concentration more than 145 milliequivalent per liter. So what is the normal level of sodium? I always ask this question to the students. What is the normal?
135 to 145.
140. 140.
145.
Good, good, very good answer. See that the level of sodium has got quite a big range, 135 to 145 milliequivalent per liter, and some students saying 140, that is the average one, okay? But rather than telling the average value, you should tell the range. Teacher will love to hear this, 135 to 145 milliequivalent per liter. So more than 145 is called hypernatremia, less than 135 is called hyponatremia. Now, moderate or severe hypernatremia is associated with significant morbidity. Morbidity means illness, and that morbidity may be associated with underlying disease, or it may be associated with the effects of hypernatremia on the brain, or it may be associated with risk of overly rapid correction. So let me explain this for you, then we move further. Okay, now see here. So what do you mean by underlying disease? The underlying disease is diarrhea and vomiting. The underlying disease may be burns. The underlying disease may be too much sweating, all those things. Or maybe the person is giving a lot of formula feeding to the child and the formula was not prepared properly. Maybe somebody is giving, you know, salt, excessive salty water or fluid to the child. So all of these may be the causes. Another one, effects of hypernatremia on the brain. We'll talk about that during the clinical feature. Hypernatremia is hyperosmolar condition on the plasma, because remember, sodium is a osmotically dominant cation. So if there is excessive sodium present on the plasma, the osmolality will increase. As a result of this, our brain will suffer. The brain will also try to synthesize some of the osmolar substances inside the neuron, and these are called idiogenic osmole. Let me explain that a little bit for you so that it will be very easy for you to understand later. These are called idiogenic osmole. So these idiogenic osmoles are synthesized, okay, synthesized by brain cells or cerebral neurons just to tackle, okay, to tackle hyperosmolar condition. Let me repeat it again. So what I'm saying here, because of hypernatremia, there is excessive osmolality in the plasma. Now, our brain cells, these are the intracellular space we are talking about now, isn't it? So they will also generate some of the idiogenic osmoles. These are hyperosmolar substances, and some of the examples of these are some amino acid, okay, and sorbitol. Okay. These are the examples, some amino acids and sorbitol. These are idiogenic osmole. These are the product of metabolism inside the neuron. So they will be collected there just to make that environment same, both intracellularly or extracellularly, so that there is no movement of the fluid. Now what happens during the treatment, sometimes we give a bit of low osmolar fluid or a bit of rapid correction of the fluid so that the extracellular compartment is rapidly corrected, means it will come back towards the isonatremic or even hyponatremic situation, but these idiogenic osmoles are still there inside the brain. So there is clear-cut imbalance between the osmolality. Now what is the principle of osmosis? The fluid always move from low osmolar space to the high osmolar space. So what happened? The fluid or the water will move into the brain cells. And what happened when fluid move into the brain cell? What we call that condition? Yes?
Hydrocephalus.
Cerebral edema.
Hydrocephalus.
It is,
They will be
okay, okay. Let me explain this. It is known as cerebral edema first, okay? Cerebral edema is the proper term here. Let me correct the spelling here. Cerebral edema. So brain cells will be swollen because of excessive fluid collection. It will lead to increased intracranial pressure, and this is a very serious situation. It can lead to seizure. It can lead to a lot of other problems. So this is what leads to morbidity in case of hypernatremia. So let's move on. Now, after this, let's talk about what are the causes of hypernatremia. So every student, please focus on the slide now. It's very easy to understand. If we take excessive sodium then we can suffer from hypernatremia, like improperly mixed formula, already talked about, because the formula has got almost double sodium than the breast milk. Excessively intake of sodium bicarbonate, it has a lot of sodium content there. And in which situation we give sodium bicarbonate to our patient? Anybody?
Metabolic acidosis.
Metabolic acidosis.
Excellent answer, both Abbas and Irfan. This is metabolic acidosis. Very good. In the treatment of metabolic acidosis, sodium bicarbonate is the drug. So if we give excessive amount of sodium bicarbonate, definitely the person will have hypernatremia. Let's move further. Ingestion of seawater or excessive sodium chloride will definitely give rise to hypernatremia. Seawater is very salty. We all have experienced that. Intentional salt poisoning. Some of the parents, okay, some of the caretaker will give excessive sodium deliberately to the child, intentionally. This is known as intentional salt poisoning, okay, or they consume by themselves. These are usually the psychiatric individuals. Another is intravenous hypertonic saline. 3% sodium chloride is used, okay, for the treatment, sometimes in the hospital. If we give a lot of that to the patient, definitely there will be hypernatremia now. Another important condition in our medicine is hyperaldosteronism. Now, what is the function of aldosterone hormone? What is the function?
Retention of water.
It
Retention of
retains
salt and water.
Sodium and water.
Very good. Every student know that. Every student know that it's a retention of sodium, and water will always follow the sodium. Okay, so retention of sodium and water. So if there is excessive aldosterone, which is coming from adrenal cortex because of some tumor or because of adrenal hyperplasia, it will lead to excessive sodium concentration in the plasma. Another one, inappropriately made ORS. Now remember those practical tips which I provided you, how to prepare ORS. Sometimes what happens if the people don't know this knowledge, they can use 500 ml of water for 1 packet of ORS. Now this is very concentrated type of ORS. A lot of solutes are there, but where is the solvent? It is half than the required. It will easily lead to hypernatremia. And similarly, if they put 2 liters of water in 1 packet of the ORS, now it will lead to hyponatremia because the sodium would be diluted. Okay, so these are relative type of things. And then just now we talked about standard, which is we're talking about the different causes of hypernatremia. So before the break, I talked about the use of standard WHO ORS as the cause of hypernatremia in children. You already know the explanation because it contains too much sodium for that age group. The level of or amount of sodium is more. It is 90 millimole per liter, okay, whereas the baby doesn't need that high amount of sodium because of the diarrhea and vomiting, or because of the dehydration which is there because of diarrhea and vomiting. The sodium loss is not that excessive, but if we give a lot of sodium containing ORS, then it can simply lead to hypernatremia. That is the explanation. And the same table I have repeated here again so that you can quickly glance through the table and know what is the explanation here. Look here, the amount of sodium in the standard ORS is 90 millimole per liter, whereas in the new or modified ORS it is 75. Because of the high chances of hypernatremia, the level of sodium is decreased here. What are the other causes of hypernatremia? Let's deal with it. The second important heading is water deficit. Now this is a relative type of thing. If more water is lost than the sodium, then there is relative over concentration of sodium in the plasma. This is called hypernatremia. And the common causes are nephrogenic diabetes insipidus and central diabetes insipidus. Now students already know the meaning or the definition of diabetes insipidus, isn't it? So diabetes insipidus occurs because of which hormone is decreased there? Which hormone?
ADH.
Aldosterone.
Yes,
ADH.
it is ADH, okay? Not
ADH.
exactly. It is not aldosterone. I hear aldosterone by some of the students. Aldosterone is not the answer. It is anti-diuretic hormone, which is also known as vasopressin. Vasopressin, that is the answer for you. Now, let me talk a little bit about that. Vasopressin or ADH is synthesized by hypothalamus, but it is stored in the posterior pituitary. When there is appropriate stimulation, and that stimulation is, okay, that stimulation for the release of ADH from the posterior pituitary is mainly hyperosmolality of plasma. If the plasma is a bit concentrated, then there is a stimulation for the ADH to be released. Now the function of ADH is it will retain only water from the collecting tubules of the kidney. Only water, no sodium is reabsorbed by ADH. So it will dilute the plasma. Now the problem here, if that ADH is lacking, if it is not coming from the hypothalamus or from the posterior pituitary, that function of retention of water is lost. So the urine would be very diluted and a large amount of water is excreted outside from the kidney. That condition is known as diabetes insipidus. It is of two types, nephrogenic and central. Central, when there is no ADH coming from the above. Above means hypothalamus or pituitary. It can be acquired or it may be autosomal dominant disorder. AD is autosomal dominant. On the other hand, nephrogenic diabetes insipidus occurs because of lack of the receptors, or if those receptors are unresponsive to the available ADH there, and they can also be acquired or X-linked recessive. Okay. Another cause of excessive water loss or deficit is increased insensible loss from the body. That can occur in a premature infant because they have a large body surface area and they don't have any subcutaneous fat. So they will lose a lot of water from the body. Radiant warmer, a lot of use of radiant warmer in case of infant or baby. Radiant warmer is a source of heat, remember that, and that heat can also lead to insensible loss of the water from the body. Phototherapy. Now phototherapy is used for the treatment of which condition? What is the answer? Where phototherapy is used for the treatment? Quickly. Okay, so the answer is neonatal jaundice. Exactly, neonatal jaundice. If a baby develops jaundice after the birth, okay, then we start phototherapy for the treatment. That phototherapy also acts like a source of heat to the baby. So as a result of that, insensible loss of water may occur and relative hypernatremia may occur to the child. Another cause may be inadequate intake. See there, ineffective breastfeeding, child neglect or abuse, and adipsia, that is lack of thirst, are some other causes of hypernatremia. It is all about the relativity, okay? Let me repeat again. Sometimes the student would have a little bit difficulty to understand this. In our plasma, there is solute and there is solvent. Water is a solvent and the sodium, potassium, other type of electrolytes are solute. So there is a good balance between them. So what we are talking here is the solvent or the water is lost or deficit more than the solute. So this is a relative type of hypernatremia. Okay, so let's move on. Now the third important types of heading for us is both water and sodium deficit. But again, water deficit is more than the sodium. It may occur because of GI loss as a result of diarrhea and vomiting, emesis is vomiting, or if there is a lot of NG tube suction. If the patient uses lactulose, which results in osmotic catharsis, Okay, lactulose. We all know where lactulose is used. Lactulose is what type of medicine? Yes.
It is used in case of
Osmotic
lactase
diuretic.
intolerance.
Like
Sir, it is a non-absorbable sugar, sir.
It is a non-absorbable sugar and it is used
Hepatic
for the
encephalopathy.
treatment of hepatic encephalopathy as well as treatment of constipation. Constipation. Remember, treatment of constipation can be done by lactulose, and one other important condition, it is used for the treatment of hepatic encephalopathy. It is non-absorbable sugar. Very good. So what is the function of this? It will draw water into the intestinal lumen and make that stool softer so that the constipation problem will be relieved. But excessive drawing of the water inside the intestinal lumen may lead to water and sodium loss. Another important cause is a cutaneous loss like burns and excessive sweating. No need of an explanation. These are well-known causes of hyper or hyponatremia. Let me repeat again, it is always a relative type of thing. Now, with this, let's enter into the clinical manifestation of hypernatremia. What are the signs and symptoms in the child? Dehydration because of GI loss or because of diarrhea and vomiting is probably the most common cause of hypernatremia. So there may be signs and symptoms of dehydration. Remember those signs and symptoms once again from head to toe. Repeat them, okay? Very, very important question in the exam. In case of hypernatremic dehydration, there is better preservation of intravascular volume. Now let me explain this. You need to have a bit of thinking here. Now see this. In hypernatremic dehydration, there is better preservation of intravascular volume. Sodium is osmotically active substance. Now in this condition, there is excessive sodium in the plasma, and that sodium is drawing water from intracellular space to the extracellular space. Blood or plasma is a part of extracellular fluid. So what is the result now? Cells are shrunken, but there is preservation of intravascular or extracellular fluid. This is how intravascular volume is maintained in case of hypernatremic dehydration. That's why blood pressure and urine output are also maintained. This is the reason for that. So the person is less symptomatic in the beginning. If we palpate the skin, there is doughy feeling. Okay, there is doughy feeling, and this doughy feeling is probably because of intracellular water loss, and the mechanism I've just explained to you. Okay, now doughy feeling means, okay, all of you know how to make roti or chapati, isn't it? So when you put water into that flour and make that dough, this is what doughy feeling is all about. When we palpate the anterior abdominal wall of this type of patient, we have exact that type of feeling in hypernatremia. Brain is the only organ which is affected in hypernatremia. Okay, so central nervous system parallel the degree of sodium elevation. So the person may have irritability, the person may be restless, weak, or lethargic. It depends on how high is the sodium level. At the same time, there is thirst, and the person may feel nauseated, but that sensation of nausea may not be there. There is slight rise in body temperature. Slight. This is not a case of infection, so the high rise in body temperature is not there. Okay, so a slight rise in body temperature may be present, and I just now told you brain is the only organ which is severely damaged by hypernatremia. So inside the brain, what happens? Let's talk about that now. There is a chance of brain hemorrhage, and that hemorrhage can occur in different plane like subdural, subarachnoid, or intraparenchymal as well. Now, what is the mechanism of brain hemorrhage? Now, please pay attention. What is happening to those brain cells during hypernatremia? They will also be shrunken. And what is the mechanism for shrinkage? Because sodium is present more in the extracellular fluid, and that sodium is drawing a lot of water from the brain cells to outer space. So brain cells are shrunken, and there are a lot of capillaries which are present, in the interstitial space of the brain cells. So these capillaries will be stretched, and there may be bleeding. If that bleeding occurs in the subdural space, we call that subdural hematoma. In the subarachnoid space, we call it subarachnoid hemorrhage. Okay, so these are the explanation. As a result of this, the person may develop seizure and coma. Coma is a very severe condition. Now, can anybody define me what is coma? Because I have not asked this question for you, and you have been hearing this coma term or clinical term for a long time. What is coma actually?
It is a state of prolonged unconsciousness.
Good, good, Uzair. Very good. Anybody else?
Lung consciousness not showing response to painful stimulus.
Without
any posture response.
good.
There is no response to any reflexes.
Very good. So see that. So many students are answering on their own way, but all of them, okay, have the point there. Okay. So let me combine all of them together. Listen here. If a person has prolonged loss of consciousness level, and you cannot arouse that patient from that level, even with painful stimuli or even by giving any type of stimulation, this is called coma. Sleep and coma look similar from outside. A person who is sleeping, okay, or a person who is in coma looks same from outside, but when I stimulate the patient who is sleeping physiologically, the person will be awake in no time. But in coma patient, I cannot do that. Even if I give very painful stimulation, the person will not wake up. By making a lot of noise, the person cannot wake up. So this is called coma. Let's move on. You need to discuss like this, because many of the students, they probably do not know this. Let's move on. Now, why in case of hypernatremia, there is a chance of seizure? One of the mechanism I just now explained to you, because of hemorrhage inside the brain. And the mechanism for that brain hemorrhage is different. Now, I am going to explain you some other mechanism for seizure. And that mechanism is during the treatment. If we decrease the level of sodium rapidly, okay, in the plasma by giving IV fluid much faster or much quicker, then this type of problem can happen. Now, what is the mechanism? See here, brain cells or the cerebral neuron, they generate idiogenic osmol to prevent the loss of its water. Now, why they develop this idiogenic osmol? You need to understand this, because outside the brain cells in the extracellular compartment, what is happening? There is excessive osmolality because of increased sodium level. So brain cells, they generate these type of substances which are called idiogenic osmol, and some of the examples are, let me highlight here, like glycine. Okay, glycine is a type of amino acid. Glutamine, okay, glutamine, and sorbitol. This sorbitol is the metabolite of glucose or carbohydrate. So glycine, glutamine, and sorbitol, these are a common type of idiogenic osmol, and they are the byproduct of metabolism which occurs inside the cerebral neuron. So what is the meaning? They are synthesized by the cerebral neuron just to tackle the increased osmolality in extracellular compartment. Everything is fine till now, but during the treatment process, you have rapidly decreased the osmolality of the extracellular fluid by giving too much fluid very rapidly. Now again, there is an imbalance between the osmolality and the the fluid which is present in the plasma will enter into the brain, resulting in cerebral edema, and seizure. So this is another mechanism of seizure in case of hypernatremia during the treatment part. That's why it should not be corrected very rapidly. And the goal is decrease the serum sodium level by 12 milliequivalent per liter in 24 hours at the rate of 0.5 milliequivalent per liter per hour. This is a little bit of practical information for you. Okay, if you don't want to remember this, it's okay. Nobody will pressurize you at this time. You just know the amount of sodium or the level of sodium should not be decreased rapidly. That is the important point. At the same time, we need to frequently monitor the serum sodium by sending the blood to the lab. Now, what are the other types of therapy or the treatment? Let's talk about them. If child is conscious, okay, the child can drink if the child is conscious. So hypernatremia is best managed with oral rehydration solution again. And this is a very safe way of managing. There is no real danger of rapid correction here. Free water and breastfeed are allowed to that child. There is no harm. And IV fluids are given only if the sensorium is altered, means there is a drowsy child. If there is a comatose child, then of course we need to go for IV fluid for the correction. Now, the same problem which has happened to the child during correction, how to tackle that or how to reverse that now? Let's talk about it. If seizures occur from brain edema secondary to overly rapid correction, we administer, okay, 3% saline during that time. 3% saline, which is known as hypertonic saline, at the rate of 4 to 6 ml per kg, and it can acutely increase the serum sodium, reversing the cerebral edema. And at the same time, whatever hypotonic fluid you are giving should be stopped. So these are the two important ways of reversing the seizure which has been developed because of inappropriate management. So let me repeat again. What are those two things? One, start hypertonic saline or 3% saline, and another one, administration of hypotonic fluid should be stopped. In less severe cases of hypernatremia, we can add loop diuretic. This loop diuretic has an important role in the kidney, isn't it? It can excrete excessive sodium and water, so it will help the patient, but make sure patient is not in hypovolemic condition. Now, what are the other treatment according to the causes? See there, please. If it is a case of diabetes insipidus, what we do now? Isn't it? We have to give desmopressin acetate. Now, this desmopressin is a synthetic analog of vasopressin. It's a synthetic substance, so it acts the same way as vasopressin. And we need vasopressin in case of central diabetes insipidus because it is decreased. Vasopressin is another term for ADH. In case of diarrhea, okay, you calculate what is the deficit fluid, what is the maintenance fluid, and what is the ongoing loss. And every student know that by now. Calculate the total amount and give to the patient. Sodium intake has to be reduced if this is the cause of hypernatremia. So all these are different points in the treatment part. Now, with the discussion of hypernatremia, let's move on to the another part of sodium imbalance, which is hyponatremia. So look at the definition first. It is serum sodium level less than 135 milliequivalent per liter. This is hyponatremia. And what are the causes now? It exists when the ratio of water to sodium is increased. What is the meaning? If the amount of water is more than the sodium, then sodium will be diluted. It can easily cause hyponatremia. Now, let's look at the causes here. One group of causes is classified as hypovolemic hyponatremia. Hypovolemic hyponatremia, and these are the common causes for that. extrarenal losses and renal losses. From the extrarenal losses, we have GI loss, which may occur because of vomiting or diarrhea. From the skin, excessive sweating or burns, and third space loss. Now, what do we mean by third space loss?
It may be due to burn or inflammation of bowel.
The fluid which is not present a good place, the X-ray in the intestine.
Good, good, Abbas, good. Zulfikar has also tried, very good. Anybody else? Anybody?
So there are fluid losses in spaces like in the bowel lumen or the retroperitoneum. In these areas are the fluid loss.
Good, good. Now the answer is correct, but still for so many other students, let me explain this. This is a very important term in our clinical medicine. The fluid is not lost outside the body in third space loss. It is not outside the body, okay? But it is present in those spaces where from those spaces fluid cannot be utilized. Means they are useless spaces if the fluid is present there. Like the peritoneal cavity or ascitic fluid, pericardial cavity if there is pericardial effusion, if there are pleural effusion, if there is edema, okay, means collection of fluid in the interstitial space, if because of intestinal obstruction, if the bowel lumen is having a lot of fluid. So these are called third space loss, and they can also result in hyponatremic dehydration. Now, second groups are renal losses, like use of excessive diuretic, thiazide or loop diuretic. Loop is the most potent, and after that thiazide diuretics. Osmotic diuretic like mannitol is the good example here. Urea and mannitol are osmotic diuretic. Post-obstructive diuresis. What is the meaning? Let me explain. Very interesting condition. If a patient has come to our hospital with hydronephrosis because of obstruction of ureter by a stone, when we release that obstruction, large amount of urine which is collected there as hydronephrosis would be going outside. Okay. This can simply lead to electrolyte imbalance. This is known as post-obstructive diuresis. And one of the conditions which we discuss in the topic of acute renal failure. After the patient recover from acute renal failure state, patient will enter into polyuric phase. A lot of urine will be passed, and during that time also hyponatremia may result. Now some other causes would be euvolemic hyponatremia and hypervolemic hyponatremia. Now euvolemic means normal volume, but the level of sodium is less, and hypervolemic is more volume and decreased sodium level. So these all are relative things. So what is that relativity we are talking about? It's a relation between volume and solute load. Now the first condition is SIADH. So what's the full form of that? SIADH. What do you mean by that?
Syndrome of inappropriate antidiuretic hormone secretion.
Excellent. Syndrome of inappropriate antidiuretic hormone secretion. Wonderful. So no need of any explanation. We are talking about that right now. The function of ADH is retention of only water. Only. If that water is excessive, it is going to dilute the sodium. But remember, it will not increase the blood volume, because to increase the blood volume, you need sodium there. Without sodium, blood volume is not going to be high. That's why it is a cause of euvolemic hyponatremia. Glucocorticoid deficiency. Glucocorticoid deficiency is this. Glucocorticoid means cortisol. Cortisol has mineralocorticoid activity. So you can understand like that. Hypothyroidism, water intoxication or excessive consumption of the water. If we give IV fluid which is hypotonic in the hospital in a larger amount, if we use tap water enema, now enema is giving fluid from the rectal route. And sometimes we use this type of therapy for the treatment of constipation, or sometime before going for GI surgery in the hospital, or in the admitted patient in the surgical ward. The surgeon wants the bowel lumen should be clear of the fecal matter, so the nurses can give soap water enema, okay, glycerin suppository, or tap water enema. If they give excessive tap water enema, probably only the water will be absorbed and it can result in hyponatremia. So this is one of the cause. Child abuse may be another cause. Somebody is forcing the child to drink only water. Psychogenic polydipsia. So this is a psychiatric condition now where the person keeps on drinking water throughout the day, and sometimes if the person doesn't drink water, the person will be apprehended or anxiety will be developed. This type of situation is psychogenic polydipsia. And diluted formula. See there, 100 ml of water is there, and only 1 scoop of the formula is added there. This is diluted. So what I told you in the beginning, you have to add 1 scoop of formula in 30 ml of the fluid. 30 ml is called 1 ounce, and that will give rise to 20 kilocalorie of energy. Not less than that, not more than that. This is the appropriate preparation. If somebody is not doing that, if they are excessively diluting the formula, then baby will get only water. The last types of causes are hypervolemic hyponatremia, and these are very easy to explain. Congestive cardiac failure is all about edematous condition. Cirrhosis of liver is edematous condition. Nephrotic syndrome, another important edematous situation. Renal failure, there is excessive retention of sodium and water in the body. Capillary leak due to sepsis, and hypoalbuminemic condition due to GI disease. One of the cause I can highlight here is protein losing enteropathy. This is GI loss resulting in hypoalbuminemia. So all of these may be the causes of hyponatremia. Let's move on. What are the clinical manifestations in the child now because of hyponatremia? Again, one of the most important organ which is involved is brain. And in the brain, the important manifestations are seizure, raised intracranial pressure, as well as coma. Now see here, anorexia, nausea, vomiting, emesis is another term for vomiting, malaise, lethargy, confusion, headache, seizure, coma, and decreased reflexes may be there because of the involvement of the brain. And how brain is involved here? So every student can answer now. It is all about osmosis. And the principle of osmosis tells us the fluid will move from the lower osmotic area to the higher osmotic area. Okay, so this is what happens. In this condition of hyponatremia, the serum is over diluted. So this is low osmotic area now, and brain. So fluid will move from the serum towards the brain, or plasma I should say, from plasma towards the brain, resulting in swelling of the brain cells that can easily lead to a lot of neurological problems. In acute severe hyponatremia, there is a chance of brainstem herniation and apnea. This is again related to raised intracranial pressure. Now what is apnea? Apnea means what?
Complete absence of breath.
That it is a type of dyspnea, sir.
It is a cessation of breathing.
Absolutely.
That is
Okay.
like cessation of breathing, sir, to be simple.
Yes. It is a stoppage or cessation of breathing. The person is not breathing during that time. This is called apnea. So it has some certain type of definition. We'll talk about that later. Just now, just remember that much. Muscle cramp and weakness is a very important clinical feature of hyponatremia. And this is probably the earliest one. That's why we often, even the layman, even the public, they know this point. If you consume less amount of sodium, your muscle will be cramping. There's a lot of spasm in the muscle, there's a lot of pain, and that is true. Okay, so muscle cramping and weakness are the feature of hyponatremia. Now, regarding the treatment, okay, please pay attention here. Water restriction is done in renal failure and SIADH. You restrict the water, especially in intrinsic type of renal failure or in acute tubular necrosis. You don't give water or extra water to the patient. We calculate how much water the person can take and only give that much. Other type of fluid are not given. And SIADH, the treatment is restriction of the fluid. The fluid is only given 2/3 of maintenance. Now, just now, I told you about maintenance fluid calculation, isn't it? So just calculate what is the maintenance fluid required, and 2/3 of that is given in the treatment of SIAD. Very easy. 2/3 means 66%. If the child needs 1000 ml in 24 hours, I'm just giving one example for you. 66% of 1000 ml is 660 ml only is allowed in 24 hours. This is called 2/3 of the maintenance, and this will take care of SIADH situation. You don't need to do any other thing. In case of low extracellular fluid, a patient can give ORS. IV fluids are given in those patients who cannot take orally or where the consciousness level is altered, and this is mainly done by normal saline because normal saline has good amount of sodium. Just like hypernatremic management, in hyponatremia also overly rapid correction may lead to central pontine myelinolysis. It is very difficult to understand the real mechanism, but it is mentioned in different textbook. The pons, okay, may be damaged because of overly rapid correction of hyponatremia. This is known as central pontine myelinolysis. Seizures would be there. So many times I talked about this, and how to manage this type of seizure. You need to give hypertonic saline because this seizure is caused by hyponatremia. So I need to raise the serum sodium level, and that is done by hypertonic saline, which is 3% sodium chloride. Anticonvulsants are not that useful for the treatment of seizure in this type of situation. So it is treated by hypertonic saline. Hypothyroidism and cortisol deficiency, you need to go for hormone replacement therapy. Don't get confused by this short form, okay? This is hormone replacement therapy. So let me ask you now, which hormone you give in the treatment of hypothyroidism? Which hormone is that? Which hormone?
T3,
T4.
Very good. It is T4. Okay. We usually go for T4. In case of one very serious situation known as mixed edema coma, you can go for T3 also. But let's talk practically. T4 is the most commonly used hormone in hypothyroidism treatment, and it is also known as L-troxin or L-thyroxine. L-thyroxine, that is the drug. And in case of cortisol deficiency, you go for hydrocortisone because this is the synthetic analog of cortisol, hydrocortisone. In case of SIADS, I have already talked about restrict the fluid to 2/3 of the maintenance. Never forget this. You have to give fluid, but that is 2/3 of the maintenance. Now, one small question I like to ask you. Okay, we are almost toward the end of this discussion. In renal failure, we know restriction of fluid should be done, but still we need to give some amount of fluid to the patient. Why that fluid is still necessary in that patient? Why? Why we need to give some amount of fluid still? Yes?
Sir, because in the renal failure, small amount
Sir,
of
to prevent the renal
kidney
failure.
work little bit, sir. Not
Okay.
completely.
Okay.
Describe the uremia.
Anybody else? Now listen here. This is a bit of tricky question, and the answer is this is called maintenance fluid. Maintenance fluid is necessary for our normal metabolic activity. For metabolism, we need water, we need fluid. Okay, that much is essential for us, necessary for us. We don't give extra fluid. That is the point, and that is always judged, okay, by how much urine the patient is producing. We take that urine output, okay, and add 400 ml to that. That 400 ml fluid is for normal metabolic activity. So if the patient was excreting just 200 ml, you add another 400 ml there and allow 600 ml in 24 hours. So this is the way of management. Which is in the last class we talked about sodium, metabolism, or some of the disorders of sodium like hypernatremia and hyponatremia. Those were the important classes. But today we are going to talk about even more important class than that. That is potassium metabolism, or in other words, what happens when potassium is decrease or increase in our body, and what are the causes and how do we manage. Now let's start with potassium metabolism. Now see here, majority of body potassium in our body is contained inside the muscle, because potassium is intracellular cation and majority of potassium is present in the muscle. So what information you got? If a muscle are damaged or injured, okay, or dead, then a lot of potassium will come out of the muscle into the circulation. Think about any those type of diseases or condition like massive injury or trauma to the body, like road traffic accident or motor vehicle accident or stampede in earthquake. What happens? A lot of the muscles are damaged, and then the potassium will be released from the muscle into the circulation. Very important cause of hyperkalemia. Majority of extracellular potassium is in the bone, okay? In the bone or inside the bone. Then less than 1% potassium is present in plasma only. So it is a very important point. Regarding the maintenance of potassium inside the cell, sodium potassium ATPase pump is playing a very important role. Sodium potassium ATPase pump. The function of that pump is it pumps out sodium and take the potassium inside. That's how potassium level is high inside the cell. Remember, sodium potassium ATPase pump, very important function. Insulin is the hormone which activate this pump, sodium potassium ATPase pump. So what happens now? When this pump is activated, potassium will enter into the cell. So it will increase the movement of potassium from extracellular space into the intracellular space. Now this principle we will utilize in the treatment of hyperkalemia. Don't forget, later on I'll extensively discuss about this. So in case of hyperkalemia, there is excessive potassium in the blood. I want to push that potassium into the cell. So which hormone will be given? Insulin. Because insulin, by activating sodium potassium ATPase pump, will push the potassium into the cell so that there will be no hyperkalemia. Let's move on. In case of decrease in pH, what we call, if there is decrease in pH, what is that condition called?
Acidosis.
Acidosis.
Very good. Excellent. Excellent. Acidosis, simply. Okay. This condition is known as acidosis or acidemia. Now, what happens in case of acidotic situation? See here, it moves potassium extracellularly. Means the potassium which is present inside the cell will move outside. So there is excessive collection of potassium extracellularly. In the other hand, increasing in pH, which is known as alkalosis, will move the potassium into the cell again. So they have exactly opposite of the effect. Whenever acidotic environment is there, potassium moves out of the cell. Whenever alkalotic environment is there, potassium will move into the cell. That's why in the management of hyperkalemia, we can give sodium bicarbonate, because sodium bicarbonate will make that environment alkalotic, so that potassium will move into the cell. This is another very important, knowledge for you. Okay, so let's move on. Now there is a receptor, okay, apart from the sodium potassium ATPase pump, beta adrenergic agonist receptor. If we stimulate those receptors by giving some drugs, okay, they also stimulate the sodium potassium ATPase pump secondarily, and then there is increased cellular uptake of potassium. Now tell me, what are the beta adrenergic agonist drug? Yes.
Adrenaline, non-adrenaline, dopamine, dopamine.
Good. Okay, good. Any other? Any other? You are missing one of the very important drug name there. Yes. Which drug you gave in the management of bronchial asthma? Which drug is that?
Salbutamol.
Salbutamol.
Albuterol,
Excellent. Salbutamol. Okay, don't forget.
terbutaline,
Salbutamol, terbutaline, ritodrine, and isosuprene. These are a very familiar beta adrenergic agonist drug, but among them, salbutamol is the most commonly used drug in the clinical practice from this group. So the same salbutamol can be used in the management of hyperkalemia because of this effect. See this? If I give salbutamol either intravenously or salbutamol can be given, okay, in other way like nebulization as well. So it will increase the cellular uptake of potassium into the cell. Whereas alpha adrenergic agonist and vigorous type of exercise, vigorous exercise, not a milder type, it causes a net movement of potassium out of the intracellular space, so that there will be increased potassium in the blood. So opposite of the beta adrenergic activity. With this basic information, let's move on. So how much potassium we need, okay, every day? This is called recommended daily allowance or recommended daily intake of potassium. It is just 1 to 2 milliequivalent per kg, not that much. And if we are taking balanced diet, we don't need to worry about the potassium intake. It is already there. Balanced diet has content of fruit, okay, fruit, and fruit are very rich in potassium. Fruits, don't forget that, like banana. Every student know that banana is very rich in potassium. All other types of fruit, whatever fruit you take example, they have certain amount of potassium in them. Intestine normally absorb around 90% of the dietary potassium. So we don't need to worry about the absorption of potassium. It is very easily absorbed. But regarding the excretion, okay, kidneys are the principal regulator of chronic potassium balance, and they alter the excretion in response to a variety of signals. So what does that mean? In case of hypokalemia, probably they try to conserve potassium in the body, means the excretion is decreased. But in case of hyperkalemia, because of the effect of different hormone or different signal, potassium excretion may be increased. That is the meaning. Now see there? Okay, let's move on. Much reabsorption of the potassium occurs in proximal tubular cells, because these are the most important cells in case of nephron, which reabsorb not only potassium, most of the other nutrients as well. And it is secreted by distal tubular cells. In the distal tubular cells of the nephron, sodium is reabsorbed and potassium is excreted or secreted with the effect of aldosterone hormone. So you need to remember the name of this hormone, aldosterone. This is an example of mineralocorticoid. And from where this hormone is released or secreted? From where? Yes?
Adrenal cortex.
Adrenal cortex, sir.
Adrenal cortex. Adrenal gland.
Very good. Adrenal cortex. Adrenal cortex has 3 zones. So from the zona glomerulosa, this mineralocorticoid is released, and aldosterone is the example. So this aldosterone, by acting on especially the distal tubular cells, it will reabsorb sodium and excrete the potassium. A minimal amount of potassium can be lost from the sweat as well. Okay, so excessive sweating can also have a bit of excretion in case of potassium. Let's move on. Okay. Now, all of you, please pay attention on your screen. This is a very important, slide for you. In this slide, the discussion on different hormones regarding the potassium homeostasis is shown. Homeostasis means potassium balance in the body. Now, see here. So let me use the pointer. Here is the aldosterone hormone. Okay, aldosterone. See this. This aldosterone, okay, everybody know the effect now. It will reabsorb sodium and excrete potassium because of the exchange mechanism. And this is again done by sodium potassium ATPase pump. Okay, this is mainly happens in the distal tubular cells. Now, how this aldosterone is released, every student know that already, isn't it? This is done by angiotensin II. This is the most important, substance or hormone, I can say. That is also a type of hormone, we can say. It is a regulator of aldosterone balance. Now, look at the effect of insulin here. This insulin will activate the sodium potassium ATPase pump in different cells, and by doing so, potassium is entering into the cell. You can clearly see here. Beta adrenergic catecholamine or beta adrenergic agonist drug like salbutamol is doing the same. It is also pushing potassium into the cell by activating sodium potassium ATPase pump. So these are the 3 important points you have noticed from here: aldosterone effect, insulin effect, and effect of beta adrenergic catecholamine. Okay, let's move on. Now, with this information, let's enter into the topic proper. What is hyperkalemia? What are the causes of hyperkalemia? What are the clinical features? How we diagnose it and how we manage it? So, let's start with the definition. When potassium is more than 5.5 milliequivalent per liter in the blood, we call it hyperkalemia. See this? Potassium more than 5.5 milliequivalent per liter. Now, this is very important topic because of a single point, that is, if hyperkalemia is not controlled in time, it can cause lethal cardiac arrhythmia, and this cardiac arrhythmia can kill the patient. That's why hyperkalemia needs to be detected in time and treated accordingly. Now, one important question I like to ask you, okay, we'll talk about this later. How to detect hyperkalemia? How to diagnose it? Yes?
Simply blood test.
Okay, good answer.
CB,
Blood test.
CBC or renal critical.
Now, good. So the most important one is a blood test. There's no doubt about it. Yeah. Okay, good. ECG, he's saying ECG. Okay, so listen carefully. Okay, this type of concept you should have if this question is asked. This is very commonly asked question in the exam. So how you answer? The first test I like to do is confirm whether potassium is high or not. that is done by, okay, sodium and potassium level in the blood. Sodium is always done along with potassium. Okay, we always love to do that. This is serum electrolyte. So if serum electrolytes show potassium more than 5.5 milliequivalent per liter, then we got the diagnosis of hyperkalemia. But that is not the complete diagnosis. What is the cause of that? We need to find. And what is the effect of that hyperkalemia in the body? To find that, some investigation has to be done. And one of that is ECG. Is that hyperkalemia affecting the heart already or not? That is told by ECG. And then to find out what is the cause of hyperkalemia, we have to do certain other type of investigation, like renal function test, because in renal failure, hyperkalemia very commonly occurs. So this is the way you have to think. Let's move on. What are the causes of hyperkalemia now? So all of you, please focus here. The first, group of causes are called spurious lab value. Spurious lab value means real, in the patient, there is no hyperkalemia, but the sample which we have taken from the patient is showing that. Now, this is called spurious lab value. And what are the causes for that? Hemolysis. When you take the blood from the IV cannula, sometimes what happens, while taking the sample of the blood, those RBC would be destroyed or they will be broken. Then whatever potassium is present inside those RBC would leak outside, and it simply or falsely show high potassium. But in the patient, there was no high potassium level in the blood. That's why we call it spurious lab value. Tissue ischemia during blood drawing. If you have put a tight tourniquet and then take the blood out, that is another cause of spurious lab value. I already told you in the beginning of this topic, whenever ischemia occurs, there would be damage to the cell membrane, and again potassium may be leaked outside. Thrombocytosis and leukocytosis are some other causes. Again, there would be leakage of the potassium from these different cells, and potassium may be falsely high in the lab value. Now, another cause of hyperkalemia would be increased intake. The person is taking more amount of potassium, like by IV route or oral route or by blood transfusion. IV or oral, and by blood transfusion. Now, IV or oral potassium is given for the treatment. Now remember, one of the important point I like to associate here, in the treatment of congestive cardiac failure, we commonly give a diuretic drug. Now, one of the common side effect of those diuretic is hypokalemia. Hypokalemia, because they excrete potassium in the urine. So to compensate for this hypokalemia, many of the physicians, they give potassium chloride solution along with diuretic. This potassium chloride solution, of course, has got potassium. So if the patient keep on taking that, a bit of more dose, or if they do not follow the doctor's prescription or order, then that can lead to hyperkalemia. That is one explanation I'm giving here. Another important cause of increased intake is blood transfusion. Now, blood transfusion is very important cause in clinical practice of hyperkalemia, because that blood, has different types of RBC. Types means the RBC which have got different life span there. Some of the RBC are very new. They may have more than 100 days lifespan. Some RBCs are already older. They may have 25 to 30 days lifespan. Some have already expired probably, who knows. So potassium is present in higher amount in the blood, And if we give blood transfusion to the patient, then definitely it is one of the cause of hyperkalemia. Okay, the more older blood we transfuse, the more higher chance of hyperkalemia. So we need to be careful. Another cause of hyperkalemia is renal failure. Now, can anybody tell me why renal failure causes hyperkalemia? I want to hear some explanation here. Yes?
Sir, because it play important role in the maintenance of potassium. So so it can lead to hyperkalemia.
Good, Zulfakar, very good. Yes, any other?
In the renal failure cell, sodium potassium phase will not working, so the potassium will not get out of the body and increase in the blood.
Okay, now I got it.
Sir, actually, potassium loss is a case of hypovolemic state. In hypokalemia, also causes GG juxtaglomerular cells of the kidney to stimulate, and renin angiotensin converting enzyme systems will be start, and also aldosterone.
Good, okay.
See, aldosterone system is activated, and that's where there will be a retention of sodium and loss of potassium.
Fine, fine, fine. Now listen, okay. Now listen carefully. This is a very important question and a concept you need to take. In renal failure, there is failure of kidney function. That is called renal failure. The kidney is not working properly. So there is very decreased urine output or decreased formation of the urine. Those tubules, okay, or those tubular cells, they are not working properly. There are so many causes of renal failure. One of the important causes is hypovolemia or hypovolemic shock. Another is acute tubular necrosis. Okay, so what is happening here? Because the normal function of the kidney is lost, and the normal function is retention of the sodium and excretion of the potassium. This is the normal function of the tubular epithelial cells under the effect of different hormone. That cannot happen when kidney fails. So what will happen now? The opposite thing will occur. If potassium cannot be excreted, it will be retained in the body. That is the cause of hyperkalemia. Never forget this, okay? If potassium cannot be excreted, of course it cannot be excreted in renal failure, it will be retained in the body, and that is the cause of hyperkalemia. Now let's move on. Another is transcellular shift. Now all of you please look at the screen there. What do you mean by transcellular shift? See this. This is shift of the potassium in and out of the cell. In and out of the cell. In this situation, acidemia or acidosis, potassium will move out of the cell. We already talked about. Rhabdomyolysis means destruction of the skeletal muscle. There is a lot of potassium inside the skeletal muscle, so naturally it will come out. Tumor lysis syndrome. Now, tumor lysis syndrome means destruction of tumor cells by chemotherapeutic agent, especially in the condition like leukemia and lymphoma. We would give chemotherapeutic agent to kill those tumor cells or malignant cell. So what will happen now? A lot of malignant cell would be destroyed. So the intracellular content will leak outside. Potassium is one of them. So this is known as tumor lysis syndrome. Along with potassium, some other contents which are present inside the cell would also come out in this situation. So let me give you important knowledge regarding that. And anybody can guess what is that another substance which come out in tumor lysis syndrome? Anybody? That is phosphate. Okay, phosphate would come out. And another important point are the nucleic acid. The nucleic acid would also come out. Okay, now these nucleic acids are purine and pyrimidine. Now this nucleic acid will undergo into uric acid pathway, and there is increased level of uric acid which is known as hyperuricemia in tumor lysis syndrome. So to make it easy for you, tumor lysis syndrome is the combination of hyperkalemia, hyperphosphatemia, hyperuricemia, and whenever there is hyperphosphatemia, there is always hypocalcemia. See this, the combination of these three or four things together is called tumor lysis syndrome. And what is causing it? The chemotherapeutic agent which we give will rapidly destroy the cells, and these things can happen. Now there is one way to save the patient from tumor lysis syndrome effect. If we give a lot of IV fluid before giving these chemotherapeutic agent, then the effect of tumor lysis syndrome can be decreased. We'll talk about that later on when we study leukemia topic. Another cause of transcellular shift is tissue necrosis. Whatever potassium is present inside the tissue would come out after the tissue die. Hemolysis, hematoma, and GI bleeding is another cause. Same mechanism. RBC would be destroyed, so the potassium will be released outside. Okay, so let's move on. Now, all of you, please focus here. What are the drugs that cause hyperkalemia? Have a look there. The important medications of the drugs are ACE inhibitors, angiotensin II blockers, potassium sparing diuretics, cyclosporine, NSAID, and trimethoprim. Now give me the examples of ACE inhibitors, please. Which are ACE inhibitors?
Captopril, enalapril,
Excellent. I'm sure every student know this example. Okay, everybody. Very good. And those are the correct answers you are giving. It ends with the suffix pril. So captopril, enalapril, ramipril, lisinopril, these are the example. ACE inhibitor, very, very important drug in clinical practice. They are important antihypertensive drug. They are important drug we use in the treatment of congestive cardiac failure. Okay, and they are also very, very important drug in the management of ischemic heart disease or coronary artery disease. Now, angiotensin receptor blocker or angiotensin II blocker. Give me the examples here.
Losartan,
Excellent. These are sartans. Very good. Sartans. Okay. Valsartan, losartan, irbesartan, okay, candesartan. So many different drugs are there. So these are very, very popular drugs these days because they don't have certain adverse effect of ACE inhibitors like dry cough. Dry cough is not caused by angiotensin receptor blocker, which is a common side effect of ACE inhibitor. Now, potassium sparing diuretic, give me the example.
amyloid, spironolactone, and trimetazine.
Good. Amiloride, very good. Amiloride, triamterene, okay, eplerenone, and spironolactone. Excellent. Okay, very, very good. So spironolactone, amiloride, triamterene, these are the different drugs. So just one or two example would be enough here. Okay, so they retain potassium in the body. That's why we always teach our medical student, whenever we talk this type of topic, do not mix potassium sparing diuretic with ACE inhibitor or angiotensin II blocker. That is a lethal combination. Both of them will cause hyperkalemia, and there would be uncontrolled hyperkalemia in the patient, which can lead to cardiac arrhythmia. This is a very poor combination you can use. On the other hand, if I combine, okay, angiotensin II blocker with furosemide, this is a good combination now, because furosemide will cause loss of the potassium in the urine, and these drugs would increase the potassium level, so they'll balance each other. Okay, so this is an important clinical explanation. Cyclosporine, NSAID, and trimethoprim are some other drug which can cause hyperkalemia. Now, let's move on. What are the clinical manifestations of hyperkalemia? Or in other words, what are the ECG finding? There is peaking of T wave, means T wave becomes quite tall and broad also. Tall and broad T wave, just like a tent. So they are called tented T wave. Apart from that, there is increased PR interval, there is flattening of P wave, and there is widening of QRS complex as well. So PR interval is prolonged, P wave is flattened, and QRS complex is wide. Some very lethal type of cardiac arrhythmia can occur here, and one of that is ventricular fibrillation, which can kill the patient in few minutes, and even asystole can happen in severe type of hyperkalemia. So we'll talk about this ECG finding in the subsequent slide. On the other hand, paresthesia, weakness, and tingling, they all occur in the patient, and they occur before the cardiac toxicity. So patient should, report to the hospital that I'm having this type of things, and the doctor may get some clue, and then ECG probably would be done, and a blood test would be done to diagnose hyperkalemia. Paresthesia is uncomfortable feeling in the periphery. Now, please focus on your screen. Okay, look at the ECG changes in case of hyperkalemia. See there? You see here, this is P wave. Okay, I'm sure you are studying this in internal medicine. Okay, this is the important part of internal medicine. P wave, QRS complex, and the T wave. So when potassium is 6.5 milliequivalent per liter, already more than normal, isn't it? It should be less than 5.5 to be normal. It is 6.5 already. So I can see a taller T wave already here. See, this T wave is quite tall. In 7, see this? T wave is still taller, and it is a bit broader also. And this QRS complex is also slightly broader than before. In potassium of 8 milliequivalent per liter, these waves, QRS complex and the T wave, they do not look normal now. Okay, they do not look normal. T wave is as tall as QRS complex, and they are quite wide. And when the potassium level is 9, I cannot even identify them. Okay, this is a clear-cut case of arrhythmia. So to make it easy for you, once again, in a different potassium level, the ECG tracings are shown here. When potassium is 6.32 milliequivalent per liter, what is happening to the ECG? There is slow heart rate already. Slow heart rate, tall tented T wave. See here, quite a tall T wave, as taller as a QRS complex, and prolonged PR interval. Now, do you know what is the length of PR interval? What is the normal length or normal duration?
0.4
0.12
0.2 seconds. 1 large square.
Exactly, one large. Very good, one large square. Very nice. It should be up to one large square, and one large square is 0.2 second. Okay, 0.2 second, just one large square. If it is more than that, we call it prolonged PR interval. So this type of things, please study in internal medicine. Okay, so that is a very nicely explained there. Now, when potassium is 7.8, there is absent of the P wave. I cannot see any P wave here. P wave should be in front of QRS complex. I cannot see any P wave. See there, it is absent, and the T wave is broader than before, and QRS complexes are also getting broader. As the potassium level increases, the QRS complex is gradually widening, and the ST segment is depressed now in this ECG. This is called depression of ST segment. You can clearly see here. Okay, ST segment depression, just like a myocardial infarction, but this is not a myocardial infarction case here. This is caused by hyperkalemia. And then when it is 9.4, very high level of potassium, of course there is no P wave, but I cannot identify these QRS complexes. They are quite bizarre. They are very wide. Okay, they are very wide. And this rhythm is obtained from the ventricle side. This is not coming from the atrial side. Once P wave is absent, okay, it is not coming from SA node. You all know that. It is probably coming from AV node or from the ventricle side. So these are some of the important ECG finding in hyperkalemia. So one statement I like to tell at the end: hyperkalemia can give rise to any type of abnormality in ECG, any type. The more common one is T wave abnormality. T wave. There is tall T wave in the beginning. There is tented T wave. It is quite broad as well. And after that, the QRS complex becoming wider and wider, and P wave disappear. PR interval prolongs, and in a very high level of hyperkalemia, cardiac arrhythmia, the life-threatening type of cardiac arrhythmia like ventricular fibrillation may also arise. Now, with this discussion, let's talk about what is the treatment of hyperkalemia. So what we are going to do in this type of case. The first thing, what is the cause of this hyperkalemia? We should think about and try to restrict. If patient is taking excessive potassium, you do the restriction in that. For example, if a patient is getting more potassium in the IV fluid, stop it. If patient is taking those fruits or those food which have excessive potassium, cut it down. So these are the important point. Now see here, high potassium level and the presence of ECG changes require more vigorous treatment. Quite definitely, this is a medical emergency. So ECG changes will lead to vigorous or quick treatment of hyperkalemia. Otherwise, you can take a bit of time. Stop all the sources of additional potassium, whether oral or IV, because this is a case of hyperkalemia. If you are giving RBC transfusion, use vast RBC for the patient who require blood transfusion, just to cut down the source of potassium there. If potassium is more than 6 to 6.5, do ECG quickly and try to see whether ECG already having features of hyperkalemia or not. And the goal is stabilize the heart in the beginning, and another goal is to remove potassium from the body. So these are the two important goals. Which is okay. Let's start again. We're talking about the goals of treatment of hyperkalemia. The first and the most important goal is to stabilize the heart to prevent life-threatening arrhythmia. That means to make the heart stable in the presence of hyperkalemia, so that high level of potassium cannot damage the heart or it cannot produce life-threatening arrhythmia. That is called stabilization, and that is done by a calcium gluconate. We'll talk about that. Second important goal is to shift the potassium from one compartment to the other, or if possible, remove potassium from the body. That can be done with the help of many different medicine or different way. Okay, so let's talk about them. The first and the most important step in the treatment is stabilizing the heart. If potassium level is very high and if it is associated with cardiac arrhythmia or some changes in the ECG, then calcium gluconate should be given without wasting any time. It is given, okay, over few minutes intravenous, and its action is almost instant or immediate. It should not be pushed as a bolus though. Otherwise, if we do that, it may lead to cardiac arrhythmia on its own. The dose is 10% calcium gluconate, 0.5 ml per kg per dose over 3 to 5 minutes. Let me repeat again, don't push it as a bolus. It can be repeated in 10 minutes. If patient is already getting digitalis, like digoxin, it should be given over 30 minutes. Otherwise, there is a chance of arrhythmia. The calcium gluconate solution should be given when there are ECG changes associated with hyperkalemia. Without ECG changes, we don't need to give it, because the main purpose is stabilizing the heart, and duration of action only lasts few minutes. So this is a very, very important drug, probably the drug of choice in the treatment of hyperkalemia. Okay. Now, another important drug in the treatment of hyperkalemia is sodium bicarbonate. Now, this drug is used to push the potassium inside the cell. So I already told you that this is one step or one way of management, shifting the excessive potassium from extracellular space to the intracellular space. And that is done by bicarbonate, or one of the important drugs is bicarbonate for that regard. So it is especially given in case of metabolic acidosis, because in metabolic acidosis, remember, potassium would come out of the cell. So we want to push that potassium again into the cell with the help of sodium bicarbonate. It is given as 8.4%, 1 to 2 ml per kg per dose IV over 5 to 10 minutes. It is strongly indicated in severe metabolic acidosis where pH is less than 7.2. In a prolonged cardiopulmonary resuscitation, the person would develop acidotic environment. pH may fall very low. During that time, soda bicarbonate is strongly indicated during the resuscitation as well. Okay, let's move on. Another important drug for the treatment of hyperkalemia is insulin. We should always mix glucose along with insulin to avoid hypoglycemia. To avoid hypoglycemia, we should do that. Okay, so here, and it works within 30 minutes. Now, what is the mechanism of action of insulin? In the beginning of this lecture, I already explained to you. It stimulates sodium potassium ATPase pump, which will cause intracellular uptake of potassium. That's how the extracellular potassium will be pushed inside the cell. The onset of action occurs within 15 minutes and it may last for at least 60 minutes, but we should be very careful. Don't use insulin alone. Always mix glucose along with insulin. Like if you are using regular insulin, 0.1 unit per kg, add 25% dextrose there, okay, and give it over 30 minutes. It will take care of hyperkalemia. Let's move on. Now, after insulin, another important drug is salbutamol nebulization, or salbutamol given through intravenous route. Salbutamol is a beta agonist, so it will also stimulate those sodium potassium ATPase pump by acting on beta 2 receptors, which will cause intracellular uptake of potassium. So salbutamol nebulization or intravenous way is another important way. Now, till now, we have talked about three important drugs: sodium bicarbonate, insulin with glucose, and salbutamol. All of these shift the potassium from outside the cell to inside the cell. They do not excrete the potassium out of the body. Now, what if we want to excrete the overall potassium from the body? Which are the drugs we have? Now, see here. One of the important way, okay, of this is loop diuretics. These loop diuretics, they increase the renal excretion of potassium by acting on the renal tubules. Furosemide is the perfect example here. If kidneys are still functioning, loop diuretics are a good choice. Another important drug which is very commonly used in the clinical practice is the exchange resin, either given per oral or per rectal, and that is sodium polystyrene sulfonate. Sodium polystyrene sulfonate, trade name is Coaxalate. So this is very commonly used. The dose is 1 gram per kg, 6 hourly per oral, or 2 to 6 hourly per rectal. Now, how does it act? The name itself suggests this is exchange resin. So it excrete potassium, and it exchange sodium for that lost potassium in the body. This is the way of action. In case of kidney failure or renal failure, we can go for dialysis, either hemo or peritoneal dialysis. Hemodialysis is much better than peritoneal dialysis, but if that is not available, then the doctor can also go for peritoneal dialysis in the patient. This is mainly used in hyperkalemia caused by renal failure, either by acute renal failure or by chronic renal failure. Now, in some of the patient, the potassium level is chronically high. This is known as chronic hyperkalemia. So how we manage that? And one of the common cause of that is chronic renal failure again. Now those type of patient, they keep on managing that chronic renal failure with the help of regular dialysis therapy. So in that condition, we should change their diet. Okay, the dietary modification has to be done. If they are taking a lot of fruits, a lot of banana in their diet, a potassium containing diet, then that should be decreased or that should be changed. If they are taking the medication which cause hyperkalemia, that should be substituted by some other medicine. In case of aldosterone deficiency, aldosterone is mineralocorticoid, and the function of mineralocorticoid or aldosterone is, let us repeat again, it will retain sodium in the body and excrete potassium. Now what happens if this aldosterone is deficient? The opposite type of effect will be there, that is hyperkalemia and hyponatremia. So to manage that, we can give fludrocortisone. This is a synthetic form of aldosterone. It should be given for a long time. And if a chronic renal failure occurs in infant, we can go for regular dialysis, because you cannot really decrease the diet or you cannot modify the diet. They need it for their regular growth. So dialysis is the most important step during this time. Okay, so let's move on. After dealing with hyperkalemia, all the important aspects of hyperkalemia, let's talk about hypokalemia now. Let's start with the definition. Hypokalemia is defined as serum potassium less than 3.5 milli equivalent per liter. The normal range of serum potassium is 3.5 to 5.5 millimole or milliequivalent per liter. So less than 3.5 is called hypokalemia. Most of the cases are caused by gastroenteritis in case of pediatric age group, or diarrhea and vomiting. Now some other causes of hypokalemia are, you can see here, transcellular shift, again similar to hyperkalemia but opposite of hyperkalemia. Okay, why I'm saying this? Alkalemia pushes the potassium inside the cell, whereas acidemia will pushes potassium outside the cell. So acidemia is the cause of hyperkalemia, whereas alkalemia is the cause of hypokalemia. Along with that, insulin, beta agonist drug like salbutamol, terbutaline, ritrodrine, and isoxsuprine, or any other types of sympathomimetic drug, and one very important genetic condition is hypokalemic periodic paralysis. This runs in the family. Okay, this runs in the family, and this may be a autosomal dominant disorder or some other types of dominant disorder, or X-linked recessive disorder may also be there, but mainly it is a autosomal dominant disorder. It is present in many different family members. So what happens here? After the person takes carbohydrate rich diet, okay, carbohydrate rich diet or large amount of rice, let's talk like this, then okay, after that the person feels extremely weak, or if that person is taking nap after that good carbohydrate meal or went to sleep, in the morning time or after a few hours of that rest, the person cannot move. So this is called periodic paralysis. Now, what is the basis or reason for that? Probably because of the hyperglycemia. After taking that good carbohydrate meal, insulin will be released. That insulin will be pushing the potassium inside the cell, leading to transient type of hypokalemia, and this hypokalemia is making the muscle weaker. This is not present in every people. Remember, this is a genetically predisposed condition. Okay, so this is important point. After a few hours, the person would be back to the normal strength. That's why it is called periodic paralysis. Very interesting situation. Let's move on. Now, another cause of hypokalemia is malnutrition or chronic malnutrition or severe malnutrition in the child. Kwashiorkor, marasmus and marasmic kwashiorkor are the perfect example here. Along with other dietary deficiency, potassium may also be less. Some extra renal causes of hypokalemia are diarrhea or gastroenteritis, use of laxative excessively, we call that laxative abuse, which also results in diarrhea, and excessive sweating. So these are extra renal losses of potassium. Whereas the renal causes or renal losses of potassium would be renal tubular acidosis or RTA, distal or proximal, diabetic ketoacidosis, and diuretic phase of acute tubular necrosis. This means the person is recovering from the renal failure caused by ATN. This is known as diuretic phase, and there is excessive production of the urine. Along with that urine, electrolytes are also lost, which results in hypokalemia. So after knowing the causes of hypokalemia, let's talk about what are the clinical manifestations of hypokalemia. Let's start with ECG change. Just like hyperkalemia, the hypokalemia can also produces ECG changes, or it can have some effect on our heart. And those are flat T wave. Remember, exactly opposite of hyperkalemia. There it was tall and tented T wave. In this situation, the T wave is flat. There is depressed ST segment, and the most important point, there is appearance of the U wave. Now this U wave cannot be seen easily in the normal ECG, means of the normal people. This U wave comes after T wave. Okay, in hypokalemia, this U wave may be as tall as T wave. Okay, or let's talk like the practical way. The T wave is flat. There is a disappearance of the T wave in hypokalemia, severe type of hypokalemia. So only U wave can be seen, and this can be quite a tall type of wave. The basis for appearance of U wave is prolonged repolarization of Purkinje fiber of the heart. Now, when the level of potassium is less than 2.5 milliequivalent per liter, the muscle weakness starts, and they start from the lower leg or lower limbs, and then the upper limbs are also affected. In very rare cases, even respiratory paralysis is a possibility, and that is life-threatening, isn't it? If the person cannot breathe, the person will die. Some of the person or some of the patient may even develop rhabdomyolysis, rupture of skeletal muscle, and that risk increases with exercise. So it is advisable to take rest in case of hypokalemia. Okay, so let's move further. Constipation is a very important feature. Constipation in case of hypokalemia, and this constipation is explained by paralytic ileus. There is loss of peristaltic movement of the intestine or the GI tract. So constipation is quite common. Similarly, there is impairment of bladder function as well, which leads to urinary retention. The kidneys are producing the urine, but urine cannot come out of the urinary bladder. This is urinary retention, and you all know how to diagnose it. Just palpate urinary bladder size there. Just put your hand on the suprapubic area. If bladder is full, this is urinary retention. Put a catheter and the problem will be solved. But try to find the cause. Until and unless you find the cause, the similar type of problem may be repeated. Another important manifestation is polyuria and polydipsia. Now, this is a little bit difficult to explain, isn't it? Remember, in case of aldosterone deficiency, there is what happened? There is hyperkalemia. Now, what is the function of aldosterone? It will retain sodium and water. So let's say in case of hyperaldosteronism, there would be hypokalemia. But why is there a polyuria and polydipsia in that situation? Because aldosterone is the hormone which will retain more sodium and water inside the body. So that is not the explanation here. Okay, the explanation for polyuria and polydipsia is in the effect of chronic hypokalemia, the kidney, okay, will start to produce more diluted urine. In the presence of hypokalemia, the kidney will form more diluted urine. And if a person keep on passing that diluted urine, then thirsty, because of excessive thirstiness, that person will drink more water, which is called polydipsia. This is the way to explain. On the other hand, there is an increased ammonia production, which may worsen hepatic encephalopathy. That's why in case of hypokalemic situation, okay, the more sign and symptom of hepatic encephalopathy will be there. That's why we do not give diuretic in case of hepatic encephalopathy or in chronic liver disease or cirrhotic patient, because more ammonia will be formed, and that ammonia will easily cross the blood-brain barrier, results in hepatic encephalopathy. So chronic hypokalemia itself can damage the kidney. We already talked about that. Now, what are the ECG changes in hypokalemia? Let's see some of the ECG tracing. When it is less than 3.5 milliequivalent per liter, we call it hypokalemia. So in this picture, the potassium level is 2.8. So see there, just a slight bulge of U wave can be seen. Still, I can trace the T wave here. But when I move further, when the potassium is 2.5 milliequivalent per liter now, the T wave is already flat. I can only see the U wave. When potassium level is 2 milliequivalent per liter, no T wave, only U wave is seen. And when it is 1.7, very big U wave is seen. Okay, the prominent U wave is seen if it is more than 1 to 2 millimeter, or it is more than 25% of the T wave. Now there is another ECG tracing which is showing the same thing. Now have a look here. When plasma potassium is 4 milliequivalent per liter, okay, there is no wave, U wave. U wave is not seen here. Okay, it's a slight bulge, we cannot even detect it. But when it is drops to 3, U wave can be seen, and there is already flattening of the T wave. U wave is still bigger at the level of 2. At the level of 1 milliequivalent per liter of potassium, U wave is massively big. So this is the very important ECG finding in case of hypokalemia. Now, how we treat a case of hypokalemia? Now, the best type of treatment of hypokalemia is the oral supplementation or oral correction. This is safe. Remember one thing, don't push potassium as a bolus form in the patient through the IV route. You will kill that patient because potassium can lead to cardiac arrhythmia. So the best way of management is oral correction. But in case of some situation, even IV is necessary. Now, what are those oral form of potassium? ORS or oral rehydration solution and syrup potassium chloride. Now, in the previous lectures, we talked about the constituent of ORS. So in one packet of the ORS, 1.5 gram of potassium chloride is available, or in milliequivalent per liter, it is 20 milliequivalent per liter. 20 milliequivalent per liter, right? So it is a good source of potassium. If it is not, liked by the patient, then we can go for syrup potassium chloride as well. In case of patient who are having heart failure and who are taking diuretic, potent type of diuretics like loop diuretic or thiazide diuretic, syrup potassium chloride has to be given together, because those are the drug which leads to hypokalemia, and this potassium chloride would balance the things up. Now, what are the IV requirement of potassium? In which situation we give IV potassium? When patient is unable to take orally, definitely. When serum potassium is low, very low, less than 2.5 milliequivalent per liter, and when ECG shows cardiac rhythm disturbances, definitely we go for IV potassium. But let me remind you again, do not push the potassium into the vein as a bolus form. Give it slowly, okay? Give it as a, mix it with the IV fluid and give it. This is the better way. The choice is potassium chloride again, and this is one of the guideline for you. No more than 40 milliequivalent per liter of potassium is added to the IV fluid, and rate not to exceed 0.6 milliequivalent per kg per hour. Now, these are all the practical, information. It is a bit difficult for you at this stage. I know that. That's why do not put a lot of stress on your mind to remember this. When you start working, all these things would be very easy for you. Or even if you cannot remember, you can quickly look and then prescribe to the patient. With this, let me stop here now.